Hello everyone, my name is Luigi Camporota and from Geyser St Thomas's in London, and it's a pleasure to talk to you about how to personalize mechanical ventilation in the ARDS patient. These are my conflicts of interests, but I have no conflict of interest for this presentation. So first of all, I would like to start with this idea. The idea that mechanical ventilation is a complex intervention that requires essentially various components, and you'll recognize the components on the right-hand side. It's a combination of PEEP, tidal volume, driving pressure, respiratory rate, and everything, or all the components of mechanical ventilation will contribute to the ergotrauma, and that will be the dose of mechanical ventilation. So the question is, how can we personalize this total dose of mechanical ventilation, but also looking at the single individual components of it? And the idea comes from, in a way, this paper when in this paper in 2007, essentially all the patients were delivered 6 mils per kilo of ideal body weight, tidal volume, and a plateau pressure less than 28. And yet, some patients had achieved lung protection. You can see at the top where the lung volume is uniform and there is no evidence of a distension. And yet some patients, you can see the two pictures at the bottom, did not achieve lung protection despite achieving the nominal tidal volume associated with best protection. And you can see there are lots of purple images indicating over distension. So then becomes clear that actually lung protective ventilation is not just given a certain amount of tidal volume or plateau pressure, but is the interaction between the tidal volume, the lung characteristics, the mechanical characteristics of the lung recruitability, the level of PEEP, etc. So you can see, for example, that if the lung is small at the bottom, there's a lot of consolidation, the one in green, then the mechanics will be different from the one at the top. There might be more or less recruitability, more or less PEEP, and therefore the tidal volume that we add on top of this patient might determine the level of lung protection. So, for example, if we think about this example here, when we are asked to scale the tidal volume to the predicted body weight, it's very clear that the scaling is based on the relationship between ideal body weight and lung volume in health, but not in disease, because each patient with the same predicted body weight with increasing level of disease, and therefore the lung becomes smaller and smaller as the consolidation increases, then the same amount of tidal volume will cause an increasing level of strain within the lung, and therefore the ergotrauma of that patient. And this becomes very clear when you can see epidemiological data that says essentially it doesn't really matter what tidal volume you give above or below a 7 mils per kilo predicted body weight. The mortality does not change and the plateau pressure has less of an influence. But what is influential is the driving pressure. So patients who received a driving pressure which was above the median had a cumulative survival that was inferior, so there was higher mortality compared to the patients who had low driving pressure. And in a way, driving pressure is essentially the scaling of the tidal volume to the lung volume, or in other words, the relationship or the ratio between tidal volume and lung compliance. And so a high driving pressure, what it does indicates that that tidal volume is too big for the level of gas volume of that particular patient. So this is one of the ways that we can scale the tidal volume to the individual patients with an individual severity of lung disease. This is clear also from this particular study, which was the Lung Safe Investigators, where they divided patients in 3 groups: high compliance on the right, intermediate compliance in the middle and low compliance on the left. And you can see patients with high compliance were essentially ventilated with, on average, with much higher tidal volume that we associate with protected lung ventilation, 8.5 mils per kilo predicted body weight. But if you can see the driving pressure is very low, 7.6 centimeters of water. Whereas if you compare it with the patients with a low compliance, those patients on average were ventilated with lower tidal volumes, but the driving pressure was excessive, 17 centimeters of water. So this is the importance and the difference between looking at just tidal volume per se versus scaling the tidal volume to the lung compliance, which is essentially looking at driving pressure. And once more recently, this paper has shown how the important is considering the level of compliance or elastance when we decide about tidal volume. So in patients with low elastance, so in other words, high compliance, there is very little difference in driving pressure in patients receiving low tidal volume or high tidal volume. But this difference becomes much more marked at high level of elastance. In other words, when the lung volume is very small. And importantly, we'll see the other point here is that at some point when we think about mean of ventilation and therefore CO2 clearance, we need to decide whether or not we are going to increase or decrease the tidal volume and therefore the driving pressure, or whether we are going to alter the respiratory rate. And this paper, in a way, gives us a little bit more information what to do. And for example, if you take into consideration this formula, you multiply the driving pressure times 4 plus the respiratory rate, what you can see here is that we can have a average number, so 4 times the driving pressure plus the respiratory rate. But you can see which factor is better in terms of personalizing in patients with low compliance. You can see the pink curve versus patients with a higher compliance, the blue curve. So if you follow the one with a low compliance and you think about increasing the driving pressure from 21 to 27 by increasing the tidal volume, and as a consequence, the respiratory rate reduced from 45 to 30, you can see what happens in those patients. That number, it goes up from 129 to 138. And with that number goes up also the odds ratio of death. So these are the patients with low compliance. Whereas in patients with high compliance, the increase in tidal volume and the increase in driving pressure actually will decrease that particular number from 76 to 73. And as a consequence of that, the odds ratio of death would also decrease. So the point of that is the choice of tidal volume depends on the underlying lung mechanics and gas volume. Now, when we go to PEEP, PEEP is a bit more complicated. There's this concept of best PEEP, where we look at the combination of best lung mechanics, best gas exchange, but also best hemodynamics, because obviously PEEP will have an effect on the venous return and therefore the cardiac output. Now, when we think about giving high PEEP, for example, and recruitment maneuver according to the open lung strategy, you can see that overall, and this is the ARDS trial, there was an increase, a 20% increase in mortality at 28 days in patients who received a routine use of lung recruitment maneuver and high PEEP. So you can see the mortality, which was 55%. There were fewer ventilator-free days, and also there was a higher mortality in patients less than 7 days. So this is quite important first message. Now, the other message came from the FARLAP trial, which essentially showed this was a study where they randomized high PEEP plus recruitment maneuver, and this study did not show any difference in terms of ventilator-free days, in terms of barotrauma, although there was a higher incidence of cardiac arrhythmias. So I think it's very important to say that when we use high PEEP and recruitment maneuver in all patients without any distinction about their recruitability, the overall message is probably deleterious. However, when we look at meta-analysis, you can see that there is not much difference between the higher PEEP and alone, the higher PEEP and recruitment maneuvers, or recruitment maneuvers alone. So no difference there. And also there is no difference whether we titrate the PEEP based on oxygenation or based on respiratory mechanics. However, we can say that some of the dynamic maneuvers that we can see following change in PEEP are very important. So first of all, it should be in patients who have a more severe ARDS, so 150 millimeter of mercury or less. You can see on the left-hand side, these patients have got higher chances of responding to PEEP. And also, you can see on the right-hand side, if the PEEP increase is associated with an improvement in PF ratio, then these patients normally will have a reduction in the adjusted probability of death. Also, it's important to understand which patients might respond to high PEEP or which ones they're going to be harmed. So this is a reanalysis of the ARDS trial that essentially will show that patients who had pneumonia and were on vasopressors, they were more likely to be harmed by high PEEP and recruitment maneuver. And also, if you look on the right-hand side, a lower mortality following the increase in PEEP was only seen in patients with the highest quintile of driving pressure. The other thing is about phenotype, and we can see in this study that actually the lower PEEP was better in terms of mortality in the phenotype 1, which was the phenotype with the lowest inflammation, whereas the higher inflammatory phenotype with hypotension was better with a higher PEEP in terms of mortality. So taking into consideration the diagnosis, the lung mechanics, the inflammatory phenotype will make us understand a little bit more what to do with PEEP. The other point is that the recruitability is much more marked in patients who have lower lung compliance to start with. And so we can do a recruitment to inflation ratio to understand which patients might benefit from further PEEP increase and recruitment maneuvers. And you can see there that when we do that kind of test, about 2/3 of the patients are highly recruitable, whereas 1/3 are poorly recruitable. And the ones that are poorly recruitable, they tend to be stayed longer in the intensive care, so longer delays from symptoms to ICU and longer delays from ICU to intubation. So that's quite important to understand. Because if we don't do these tests and we apply high recruitability, high recruitment maneuvers and high PEEP, then the volume trauma that is generated by inflating the lung with PEEP will increase the inflammation and therefore the volume trauma, the static volume trauma. And one last thing which is important is that some of these patients will also we need to be careful when we transition the patients from a mandatory ventilation to a spontaneous ventilation. And you can see here, for example, if the respiratory drive is very high, as we can see from a PO1 that is greater than 4, or an occlusion pressure that is more negative than -15, these are the patients at very high risk of relapse and respiratory failure. And you can see about 2/3 of these patients with high drive and high effort had a relapse in respiratory failure, compared to 0% in patients with low respiratory drive and effort. And in summary, I would say that mechanical ventilation, or the dose of mechanical ventilation, is dependent on a lot of the various components of mechanical ventilation. And we need to think about the individual components and how they interact with the diagnosis, with the phenotype, and with the lung mechanic of the patient. And with that, I would like to thank you for your attention.